Yeah, good morning, everybody. Thank you for this kind introduction. I'm really happy to be here in Athens. Thank you for the great course and organization. It's been tremendous and really terrific just to come in here and see this room already. I have no conflict of interest related to this talk. So why do we even have to talk about humeral side defects and bone lesions, and especially the Hill sacks? Isn't the glenoid enough? Like, we measure a lot, and why do we also have to be concerned about the humeral side? It's because it's an independent risk factor. So if you take everything out and just look at the Hill sacks lesion, you will find that this itself limits your outcome. So it has a 1.7-fold increase in recurrence rate if you just have any structural lesion on the humeral head. And it increases even to 3.3 times of the risk for recurrence if it's an off-track lesion. So, and you're most likely to see it. In over 50% of the cases, primary dislocations, they will have some kind of structural damage to the humeral head. And this important increases with recurrence. In almost over 90%, you will find a Hill sacks lesion in recurrent dislocators. And now, over time, we try to find a way to evaluate those. But it's a lot more difficult than it is for the glenoid side because it's position dependent on where this defect actually comes into a problem. So we kind of went away from having a single number. So we started out with somewhere around 12.5% of the humeral head diameter being at danger kind of size, and went towards more a dynamic understanding of this whole concept. And that's where the on and off track concepts come into handy, developed by Di Giacomo and E.G. Itoy. And then we have this intraoperative evaluation of engaging and non-engaging, where you take out the shoulder, move it, have the scope inside, and you can actually see and evaluate if this Hill sacks is engaging or not. So the cool thing about those scoring systems and about the glenoid track system is that we have something in our hands to pre-operative evaluate if this lesion needs to be treated or not. So we can better talk with our patients. And you just already saw the ISIS score. And by now there's, I would say, like an advanced or an evolution of it. It's called the GTIMS, the glenoid track instability measurement system. It's also developed by Di Giacomo. And the main difference in here is that they went from just the plain radiographs to CT evaluation when considering their evaluation of the humeral head defects. And you can see here, not on the ISIS score and not on the GTIMS, you will find glenoid-sided bone loss. So you only see humeral head defects. This is like how important this seems to be. And when comparing those two scores, there's a multi-center study that did that. While using the GTIMS, you will use less ladder J procedures. So 2 times more ladder J procedures were indicated by using the ISIS score when looking at the same pictures. Well, there will be no difference in outcome and no more recurrence rates if you use the GTIMS score. And then, as I already told you, I really recommend that for, especially in cases where you're not quite sure and you have like this subcritical bone loss glenoid side and also find a Hill sacks, use your scope and really check if they engage or not, because this is by far the most severe sign you will find, and when they indicate, like when they engage, you have to treat that. So understanding the glenoid track concept is something that it always looks nice on the pictures, but sometimes it's not so easy to understand what's actually happening. And the glenoid track concept is nothing else than the relationship between the humeral head and its surface, meaning the glenoid. So it's kind of a road and a wheel that is on the road. And if you have no damage, that wheel continues on the road without any problems. And then you get, on both sides you can have problems. For example, if you have, a hole in the street, it means nothing else than you have a small defect on the glenoid side. If you have nothing on the humeral head side, you'll still be fine. If you have a combined lesion, so you have a Hill sacks and a small glenoid defect, then this is something you have to consider, and it may even be a problem that this wheel may get stuck in that hole, and that will relate to a redislocation. And it's even more severe when you have, larger bone defects on the glenoid side. Then even small defects on the humeral side will add up to really have this problem of loss of contact, which is nothing else than a redislocation. And now you have to evaluate preoperatively, and there's a simple way on doing that. You just measure the width of the glenoid side on an axial MRI, and you would do that at the level where you would put your circle for the measurement of the bone defect. And you measure the defect size medial to lateral, beginning at the rotator interval to the medial end of the defect, and then you just compare those two distances. And if the glenoid side is smaller than the humeral head size, then you have a problem. There's a more scientific way, and this is what you just showed, that there's a correction factor. It's 0.83. It's evaluated in the lab. It's based on external rotation and abduction motion. And this is, if you really want to go into this, this is where you have your cutoff value. And why do we do that? Because even if we treat patients conservatively, the off-track lesion is a risk factor. I've done a study on that with 54 patients, mean age 29. They decided on their own, doesn't matter what I said, they did not want to do surgery due to several reasons. And 100% of their off-track lesions, which were seven patients in this group, they all redislocated. 54% of them with head Hill-Sachs lesion that was on track dislocated, and only 27% with no structural damage on the humeral head redislocated. So there's really a distinguished difference between those groups. And it's also true for arthroscopic Bankert procedures that the Hill-Sachs lesion is a risk factor. The larger the defect, the more likely you will get a redislocation if you not treat this additionally. So how do I do it? I also get the 3-plane X-rays, as you just saw, and MRI is my first choice for any first-time dislocations. I use the MRI whenever the soft tissue is more likely to be injured, and I strongly recommend to get an MRI for all patients over 40 years because there's suddenly an increase of additionally rotator cuff tears. I use CT whenever I suggest that might be a bone procedure needed, and I especially get CT scans after lock dislocations, revisions, and large size defects. Most important when you get a CT scan for me is that I do the multiplanar reconstruction myself, meaning I align the glenoid, the en-face view by myself. I do not take into account that the radiologist did this like his way, so I want to do this myself. And especially for the beginning and for evaluating the Hill-Sachs defect, I really think a 3D reconstruction helps you to understand where that lesion is located and how the size actually contributes in a 3D dimension. So this is just a simple example. So it's standard MRI axial view. And you can see this is the measurement that I do in clinic on site right next to the patient. So I just draw a circle and I measure the medial to lateral extension of the Hill-Sachs, and then I just check if it's on track or if it's off track. And this helps me. It takes not even a minute, and you'll have an answer of how to treat this patient. And just for a quick run through, this is how this affects my treatment options. So if I have no bone loss either on glenoid or humeral side, I'll do a Bankert repair. When I have the combination of a small glenoid defect and also Hill-Sachs lesion, this is where, depending on how big the size of the defect on the glenoid side is, that Bankert repair is not enough in my eyes. And you probably will see a very nice study from Manos here, that when you add the remplissage to those patients, you will actually improve their outcome by a lot. So how do I do it? Remplissage by now, it's really nice because you have all those really small and soft anchors. You put them in, cutaneous tendinous, and then you just have 2 or 3 suture passages depending on the size, and you use 1 or 2 anchors depending on the size, but you really do not make a huge damage to the tendon anymore. It's completely different than a couple of years ago when we tried to put like 4.7 or even bigger anchors through the tendon. You really create a hole. Now it's really nice with those small anchors. Back to this one, so no humeral head defect, but small glenoid defect. So I think this is right now the really hot topic, because this is where we all know that the Bankert is not the best option, and we do have some evolving options that we will see here too. So we have the ASA procedure, or we have the DAS procedure, and what that is you will find out, I guess, today. And then of course The larger the lesions get, the more invasive our surgery will be. The Latarjet is my treatment choice for gallerian defects. And you also can combine the Latarjet procedure with the remplissage if you need to, and especially when there's a huge Hill-Sachs defect. So let me conclude. Hill-Sachs lesions are an independent risk factor, and they need to be evaluated and they need to be treated. The green track concept will help you to actually pre-operatively assess your risk, and the GTIMS may work as a guide, especially in the beginning for your decision-making process. Thank you very much.